Yes, thank you very much. It's a great pleasure and privilege for me to be here to talk about my dear friend, mentor, and colleague who died this year. I first met Alasdair 50 years ago, actually, in 1974, when I was a young medical student in short trousers. And at that time, he had already become famous, and yet he was very humble, so humble, I'm sure, that he wouldn't really be terribly happy with anyone standing up and talking about him now that he has passed. But he led a fantastic professional and family life that is well worth celebrating, and hopefully will inspire the young people here just as I was inspired when I was young and first went there as a medical student to Birmingham. Alasdair was a great servant of Isaac over many years, starting perhaps as far back as 1975, when at short notice the British Society for Antimicrobial Chemotherapy, which had just formed, was elected to host the 9th International Congress of Chemotherapy in London. And Alasdair was chair of the programme committee and clearly worked his magic very successfully with some inspired choices of speaker like Ernst Chain, the Nobel Prize winner for his work in developing production of penicillin during the war. Penicillin first released in 1942. And over the years, he was a regular participant at Isaac meetings. And then, with the death of his dear friend J.D. Williams, who was editor-in-chief of the journal, Alasdair took over in 2005 on a temporary basis, which went on for 10 glorious, very successful years as editor-in-chief of the journal. And we see a few photos of him here, of great note, perhaps the photographs here with John MacDonald, the editor of Lancet Infectious Diseases, who he worked very closely with, and the photo in the middle at the bottom of the Fiona Mackenzie, the executive officer of chief executive officer of Isaac. And there are many past presidents, including Teresita Amatzi and Kurt Naber, pictured with Iger, and other celebrities. And then over on the right in the middle, Alasdair's wife, Angela, who survives him. Most importantly, perhaps in terms of Isaac work, Alasdair was an awardee of the Hamao Umezawa Award in 2015 for 50 years of work on antibiotic development. Alasdair came from relatively humble origins in the north of Scotland, born in 1934. The real Scotland, as Donald Trump would have said. He got an award, scholarship to come and study medicine at Edinburgh University Medical School, which you see here, which interestingly was modelled on an Italian monastery built in the latter half of the 19th century. So Alasdair arrived there in 1951, and at that time the rector of the university was the celebrated Nobel laureate Sir Alexander Fleming, who of course was the first to discover penicillin. In 1951, it's worth reflecting that the only antibiotics available for clinical use, apart from the sulfonamides, were penicillin, benzylpenicillin, streptomycin, chlorotetracycline, neomycin, and I think vancomycin, and that was all there was. But Alasdair proved an adept student and got excited with infectious diseases. I think because primarily it was the beginning of the golden era of the development of antibiotics. And he trained laterally with the great James McAsh Murdoch in Edinburgh, who was a very early antibiotic trialist and worked with other famous names around the world, such as Ed Cass in America, doing a lot of work on early diagnosis and treatment of urinary tract infection. So after a brief spell in America, finishing his training, Alasdair took up a post as a consultant in infectious diseases in Birmingham in 1967. Interestingly, just 1 year after a UK outbreak of smallpox, which had, although it had happened, some of the cases in Birmingham, at that time, it was decided to destroy the local smallpox hospital by fire because it wouldn't be needed in future. And you see an interesting quote from Alasdair that he, at that time, of course, with the great antibiotic era in full swing now in the late 60s, a lot of people were wondering what on earth we needed infectious disease physicians for. What else would they be doing except culturing themselves? Clearly proven wrong. The site of Alasdair's greatest work, I think, is this rather mundane-looking isolation unit, the original East Birmingham Hospital, built in 1895. In the 1960s, it became quite a significant district general hospital, but the isolation wards, where Alasdair worked from his arrival in 1967, continued very much like this. So this is really just as I remember them when I first went as a student on an elective in 1974. And you couldn't have imagined how that just 6-week visit of mine really galvanized me and electrified me into the potential for studying infectious diseases, microbiology, and antibiotics. Even more mundane were the offices where all the great papers are written. They were a set of porter cabins just on the left of this picture. There really was nothing terribly exciting about the physical presence here, but the excitement, the intense work, the camaraderie. Already when I came in 1974, 7 years after Alasdair began his work here, this was a world-famous centre for antimicrobial trials, and there were numerous people from all around the world, including perhaps, I may be wrong here, but Serhout Unal. I just remember meeting him about that time, and it was either in Birmingham or London. So it really was one of the places to go and to study. And even yet, Alasdair was always humble, in charge of these great retinues on the wards, but he was always, he had half a dozen experienced clinicians examining every patient, but he was always there before anyone at 7 o'clock in the morning checking on every patient. And yet, here was a rapidly becoming world famous physician, researcher, teacher, and mentor. And a series of papers came out from these early days on newly discovered, newly formulated antibiotics such as cotrimoxazole. Treatment of salmonella infections, perhaps an odd choice, but as we'll see later, because of a mass influx of Indian subcontinent people to live around Birmingham because of the traumas that were going on at that time with the splitting of Pakistan into Bangladesh and Pakistan. There were a lot of refugees and people going back and forth, and a lot of typhoid and malaria and many other tropical diseases were adding to the excitement and the potential for clinical trials. A lot of work was done in the early days of the availability of clavulanic acid And another fascinating story, which I haven't seen anything published on, but I know it's true, was that Alasdair was chosen by Merck Sharp and Dohme, MSD, the big American company, to give imipenem to the first human volunteers to study the pharmacokinetics. And they couldn't find any imipenem in the blood of the human volunteers. And of course, this then rapidly led to the realization that the imipenem was being hydrolyzed by a dihydropeptidase in the kidney and needed the silostatin to protect it before it could be of any use clinically. His work was recognized pretty early by senior academic appointments at the University of Birmingham. But perhaps one of the big issues of his life professionally and emotionally, I think, was had really started into motion some 180 years before with the first well-documented attempts to prevent smallpox by immunization. Of course, Edward Jenner using the cowpox virus from the milkmaids to protect his young patients. And Jenner soon saw the prospect for eliminating what was a terrible, terrible scourge which had affected mankind for several millennia. And things snowballed from around the date of 1966, the outbreak of smallpox in the United Kingdom. And WHO soon picked up the gauntlet after some debate, but eventually in 1966 being allocated $2.4 million to eradicate smallpox from the world. Sounds like good value for money today. At that time, smallpox was still endemic on 3 continents. But by 1973, when Alasdair really got involved, it was really just the Horn of Africa and the Indian subcontinent that were the big issues. And perhaps strangely, but a very forward-seeing bureaucrat in the English Department of Health saw that it might be sensible to teach 1 or 2 infectious disease clinicians about smallpox because it seemed that it was rapidly disappearing. But there were always concerns that it might be used in bioterrorism. So Alasdair was sent for several weeks to Bangladesh, where, as I've explained, there was a great flux of people because of the formation of the country from East Pakistan. And there were lots of cases of smallpox. And here is a photo of Alasdair with his main way of getting around when he went to Bangladesh to learn about the clinical presentation of smallpox and to understand and control its spread and to help in the vaccination of the ultimate control of smallpox, which I'm sure was exciting. Here's Alasdair in a boat getting to one of the hinterland villages, and he saw lots and lots of smallpox. So by 1977, it looked as though things were really virtually solved. All the problems that had been anticipated had been dealt with, and the last remaining case of smallpox, if you like, naturally acquired smallpox, was in 1977 in Somalia. And this led to the declaration, famous declaration, 1980, of the death of smallpox. But there's one significant happening which I haven't mentioned. In 1978, 1 year after the last clinical case of smallpox, in East Birmingham Hospital, 1978, a patient was admitted, having been passed around by several general practitioners for several days, unsure about exactly what the diagnosis was. Admitted to East Birmingham Hospital, Ward 32, the infectious disease ward, where I had just finished a second stint of training as a senior house officer. And Alasdair was called in and made a diagnosis of smallpox. So this is 1 year after the last case had been declared. Unfortunately, this lady did not do well. She died. Her mother was the only other secondary case because of fairly efficient infection control measures being put in place. But what transpired was that she worked as a medical photographer in the university in the floor above the smallpox research laboratory, which was still operating under some questionable guidelines, having been cautioned by WHO some years before. And here's an actual, not very good quality picture, I'm afraid, of the medical school, showing the laboratory on the first floor and the windows, and above where the medical photographers worked. And it is almost certain that there was some airborne transmission of this highly infectious virus which led to this tragic case. This obviously put Alasdair at the forefront of a diagnosis of smallpox again some years after he had mercifully been in the thick of it in Bangladesh. It was a traumatic time for him, I know, because the professor of microbiology who ran the smallpox laboratory was put under great pressure because it was soon seen this was highly likely to be a laboratory release, and the professor killed himself by slitting his throat in his garden shed a few days after the case came to light. Alasdair took more interest in because both the index case and the mother had been vaccinated previously, took some interest then in actually what was the duration of efficacy of smallpox vaccine. And he investigated this small epidemic that had taken place in Edinburgh in 1942. And one of the significant things he noted was that if you go down to the bottom of the slide, of the approximately 250,000 people who were vaccinated, 10 died from the vaccine, 8 from encephalitis. And he was able, with this knowledge, to advise Donald Henderson, one of the people leading the WHO eradication campaign. He was able to advise Donald that it was not a good idea then to do what was being proposed after the Twin Towers 9/11 terrorist attack in New York. George W. Bush was keen to vaccinate the American population against smallpox in case of bioterrorism. But with this sort of data, the decision sensibly, obviously, was taken not to vaccinate the population. But it did take people's minds, including particularly Alasdair's mind, back to the fact that this was probably a second accidental release of smallpox from this one laboratory in England, given that the index case in 1966 was also a medical photographer in the university in Birmingham working above the smallpox laboratory. So that was 1966 and then 1978. And then in 1977, indeed, it looks like there was another significant accidental laboratory release because there was a most peculiar pandemic of H1N1 influenza centered around Russia and northeast China, where genetic studies showed this was virtually identical virus to one that had been in circulation around the world in 1950 and had had no significant mutations in the 27-year period. And there were several papers written at the time, but not a lot else was said, but perhaps because of the Cold War. This indeed looked like presumably unintentional release of a strain that had been stored, frozen, and was perhaps being investigated for its vaccine potential or other particular issues. So I know that all concerned Alasdair. I spoke to him a little about, of course, the next great pandemic where there may be issues of accidental laboratory release, although the jury clearly is still out, and it may well take several decades to actually come to a conclusion, I should say, about exactly what happened. So I hope I've given you some feeling of just what a great teacher, mentor, researcher, clinician Alasdair was. Many of you in the room will know him, will have encountered him. He was always a gentleman, always very humble, very helpful, a great family man, as Angela and his children will testify, but also he had another family that literally hundreds of infectious disease and microbiology students who he steered into very successful professional careers, and I know he is particularly proud of that. So thank you very much for the chance to deliver this oration to a true hero, I think.